Hello, good afternoon, and welcome to Stony Brook Medicine. And thank you for everyone for joining us this morning and afternoon. My colleagues and I are from Stony Brook Medicine, the Department of Obstetrics, Gynecology, and Reproductive Medicine, specifically from the Division of Maternal-Fetal Medicine. Although most pregnancies are routine, there are several pregnancies which can become quite medically complex for both the mother and the baby. And so we're here today to explain some of these conditions and go over some questions and hopefully answer any questions that you may have in the audience today. My name is Dr. Kimberly Herrera. I am a clinical associate professor of obstetrics, gynecology, and reproductive medicine for Stony Brook Medicine, and I'm a maternal-fetal medicine specialist. I particularly like opioid use disorder in pregnancy, as well as diabetes in pregnancy, and education of medical students, residents, and fellows within maternal-fetal medicine. I'm joined today by 4 experts in the department, and I wanted to introduce them and go around in a circle. First, we have Dr. Diana Garretto, who is a clinical associate professor. We have Dr. Jennifer Choi, who's a clinical assistant professor in our division. We also have Dr. Cassandra Heiselman, a clinical assistant professor. And we have Dr. Omar Abu Zaid, who will be graduating our fellowship this year with a maternal-fetal medicine degree as well. So I wanted to welcome our panel to the live stream this afternoon. And since we have a lot to get forward to and a lot of questions to answer, I'm sure, I just wanted to jump right in. So please, during the live broadcast, please feel free to ask questions within the chat or to use the QR code as well to post your questions, and we will get to them as best as we can. So let's get started. So first question is for Dr. Garretto. What is considered a high-risk pregnancy? What sort of complications or examples can you give us for the audience?
So similar to what you were saying also, I mean, pregnancies can start complicated by maternal issues or become complicated by fetal issues, as well as ongoing pregnancy-related maternal problems or even fetal problems. So really, we run the spectrum of any system of the body in terms of maternal issues, starting with a chronic condition will generally lead you over to maternal-fetal medicine at minimum for a consultation. Some women need to stay with us for their entire pregnancy. And then some other women will come over more for fetal issues. So anatomy sonogram then identifies a problem with the baby, will sometimes lead you over to see us to ask questions, to talk about a plan of care. An ongoing issue with the baby, growth restriction as an example, can be something that you'll end up followed throughout the pregnancy and make your plan of care. And then things that are pregnancy related only can be things such as like preeclampsia, blood pressure issues in the pregnancy, that are really only an issue just for pregnancy and not necessarily outside of it. So we really run a wide range of different problems that we take care of in the pregnancy.
Thank you. A follow-up question for that, I suppose, are twins considered, or more than twins, multiple gestations considered a high-risk pregnancy?
So great question with it. Generally, twins need at least a discussion with maternal fetal medicine doctor to talk about the potential many complications that can occur. It's all about how the placentas and the sacs are separated and what basically the babies share with each other in terms of how complicated a pregnancy can become. So the more things that are shared, such as the placenta in a monochorionic pregnancy, or if the babies are sharing a sac, like in a monoamniotic pregnancy, the more complicated the pregnancy can become. So many times a woman will meet with us at the beginning of pregnancy, and then we decide and discuss about the potential complications and how closely we need to follow.
Great, wonderful.
The other thing, too, I'll add to what Dr. Garretto stated, is that oftentimes we will see women who are high risk for either fetal or maternal conditions in pregnancy. We also have the chance to see people preconception as well. So if you had an adverse pregnancy outcome that happened in a prior pregnancy, recurrent pregnancy loss, stillbirth, or just a complicated postpartum, intrapartum, or prenatal course, oftentimes we can see patients beforehand and put a plan of care in place for the next time they get pregnant. So it's also a nice opportunity for a patient to kind of go through the complications, whether that be maternal or fetal, from their prior pregnancies, and come up with a great kind of plan to put into place to kind of decrease the risks of those things happening again in their subsequent pregnancies, and have time for them to kind of ask us any questions about what their risks might be in future pregnancies.
Wonderful. Great point. Exactly. Perfect. So we're going to switch gears a little bit and head over to Dr. Abu Zaid. So can you let us know and fill us in as far as training? What is the differences to become a maternal fetal medicine specialist in regards to training and education? And how is that different from a general obstetrician?
So for the general OBGYNs, we along with all of them, do 4 years of training in the full breadth of obstetrics and gynecology. And then following this, for us as maternal fetal medicine specialists, we do a subspecialty training, which is an additional 3 years, where we learn maternal and fetal conditions and how to become great consultants for our general OBGYN colleagues, as well as come up with plans of care for maternal and fetal conditions.
Great. Wonderful. So switching to our next question for Dr. Choi, can you explain to the audience when is it appropriate for a patient to seek a maternal fetal medicine specialist? For example, are there any particular conditions or maybe signs or symptoms of pregnancy that they should be alert to, that they should come to see us?
Sure. Any patient who has a concern or question about their pregnancy before and after can be seen by a maternal fetal medicine specialist. And like Dr. Heiselman had mentioned, patients come to us for preconception consultation, and those are for patients who have pre-existing medical conditions, who have a history of miscarriages, like she mentioned, recurrent pregnancy loss, and infertility concerns. So like Dr. Heiselman had mentioned, we sort of talk about a plan of care from there. I would always encourage you to talk to your obstetrician as well as gynecologist and see where you stand if there are any concerns that remain afterwards, and you're more than welcome to be referred to us. Typically, patients are referred to us for pre-existing medical conditions. To name a few that Dr. Garretto had mentioned, you have hypertension, diabetes, kidney concerns, infectious disease medical conditions, but patients also who develop complications during the pregnancy. Those would be gestational diabetes, preeclampsia, preterm labor, preterm contractions, placental abnormalities. We mentioned this briefly earlier as well, but we are seeing a lot more multiple gestations. So those are twins and triplets, as well as patients who have fetal anomalies on ultrasound. So if they have any of these findings, they would come and see us and speak to us about that. I would say that pregnancy is a really, really happy journey for all of us, but these conditions can make it quite stressful. So we're kind of there to just walk that walk with you, just be there for you in collaboration with our NICU and pediatrician teams.
Yeah, I do want to echo your comments too about having an open dialogue and an open conversation with your providers, because there is a spectrum of a lot of these diseases and complications that can happen for the mom and the baby. And so just making it a more secure place and a more happy time and put everyone's mind at ease is what we're here for as well. Thank you.
Thank you.
Okay, so moving on to Dr. Heiselman, can you explain some perhaps unique testing or procedures that we do in maternal fetal medicine and why that might make someone high risk, or different test methods that we might use for them? For example, ultrasound or blood.
Absolutely. So a lot of what we do outpatient is both consultations, like we talked about, as far as medical conditions go, both in and outside of pregnancy. And then a lot of times we also are on the spectrum of dealing with any abnormalities that come up with genetic screening. And then we go forward and talk more about testing. Could you please show, I think it's genetic photo 2, please? So this kind of goes into sometimes why we're referred. So all women in pregnancy are offered genetic screening for chromosomal abnormalities. Another word for that is aneuploidy. So there's two different things. There's screening and there's diagnosis. So screening tests are often what happens in a general, in OB practice, and it is something that we can screen to see if you have an increased or decreased risk of a sort of chromosomal abnormality or genetic abnormality. Often, if those screening tests are positive, you then are referred to us to kind of talk about what your actual risk of having, or the baby's risk for having this condition is, and what we can do to then diagnose it. So the diagnostic side of things is a little bit different. Could you show photo 3, please? One of the most common screening tests that you will talk about is cell-free DNA. People will also refer to it as non-invasive prenatal testing, non-invasive prenatal screening. As you kind of see here in this depiction, it actually is taking little bits of the placental DNA that comes into the mom's bloodstream, and little fragments of it are actually tested to see if there's any of the high-risk abnormalities, things like Down syndrome, trisomy 21, 18, or 13, the most kind of common things that we see as far as chromosomal abnormalities go. And so if something like this pops up in a positive or increased risk, we then talk about diagnostic testing. So if you could put up photo 1, please. So screening says increased or decreased risk, whereas diagnostic testing is going to be, does the baby have this or does not have this condition? Where we're actually taking fetal cells, whether that be the placenta early on with what we call a chorionic villus sampling, or an amniocentesis, which is what you see in the picture here. So it is a transabdominal test where we do take a needle and get a sample of the amniotic fluid. We do this in our own sono unit under ultrasound guidance. So that is one of the ways that we can actually get the cells of the baby and actually have those cells tested to tell you yes or no definitively. And that is the only way to actually say for certain that the baby does have this condition or doesn't have this condition. So a lot of our counseling actually revolves around genetics and probabilities as well. And then we kind of talk about how we can also screen with sonograms. So looking for structural abnormalities that may also give us a clue of whether there is something genetically wrong with the baby as well. And then sometimes kind of flipping on the non-genetic or structural abnormality side of things, certain conditions moms have put them at higher risk of certain complications in pregnancies, things like growth restrictions, the baby is just not growing as well, placental insufficiency, and sometimes things that are scary like a stillbirth. So we put into plans basically kind of increased surveillance a lot of times with sonograms. So you are coming to our sono unit every 4 weeks or so to measure the growth of the baby, or sometimes in the 3rd trimester you're coming to see us weekly for biophysical profiles where we're doing a fetal well-being check. So is the fluid good? Are they moving? Are they practice breathing? And all of that helps us to basically look for things to intervene before bad things happen. So like ultrasound is one of our main ways that maternal fetal medicine can help manage and also to watch out for bad things happening in a pregnancy.
Great, thank you. And I do want to echo your comments that within our field, there is a lot of surveillance, whether it be of the mom or the baby, with a lot of ultrasound, which is a safe modality. And we do practice that a lot to be able to give peace of mind for both the mom and the baby. So I do want to echo Dr. Heiselman's comments and, give her credit for what she described as far as our day-to-day testing. We do have a question for the audience that I just wanted to interject. The question is, and this is, for anyone, if I had a high-risk pregnancy before, does that mean that I need to see an MFM doctor for my second pregnancy?
Do you want me to answer it, Kim? I'll take it.
Sure, no problem.
Okay, so if you had a high-risk pregnancy before, so it depends on what the issue is. Many issues of pregnancy are repetitive, so you may have an increased risk of something happening again. There are some events that are isolated. One example could be something like a placenta previa, where the placenta is covering the cervix. So there's bleeding and complications that can come from that we may file you for in a prior pregnancy, or like Dr. Herrera or Heiselman had said before, like a vasoprevia, which is very much related to just one pregnancy, that may not necessarily predispose you to having an issue in your future pregnancy. So, if it's more related to a chronic maternal issue, then yes, you probably need at least a consultation with maternal-fetal medicine. If it was an issue of an abnormality of the baby, such as a congenital anomaly, it may require early surveillance of the baby in a future pregnancy, and then not necessarily beyond that. So each situation is a little bit unique in terms of what you need in a future pregnancy. But at the minimum, it's always worth discussing with your doctor, or even discussing with us in a preconception consultation to see whether there is special plan of care that you need.
Perfect. Thank you, Dr. Garretto. And sort of to seg into that, our next sort of roundtable question for you, Dr. Garretto, is similar to that, but how do you lower your chances of having a high-risk pregnancy, perhaps if it's your first pregnancy in general or subsequent pregnancy like we were just discussing, how would you lower those risks? Are there any interventions or medications or lifestyle things that you would recommend?
So, just like we just spoke about and mentioned, preconception is incredibly important. The optimizing any medical condition that's happening chronically can help reduce the risk of an issue during a pregnancy. So preconception consultation is a underutilized but extremely useful way to set yourself up for the best pregnancy outcome and to understand what your risks are. So that would be the best way. That would lower your risk overall. What was part 2 of your question?
Oh, part 2 are just any other sort of medical interventions or treatments or surgical procedures that are sometimes recommended to prevent high-risk pregnancy.
So medical is what we said, optimizing any chronic medical conditions. Surgical, some situations come up where surgical may be something helpful. A large uterine septum, perhaps removing that will reduce the risk in a future pregnancy. Uterine myomas, fibroids in pregnancy, some that are in a more problematic location that may have caused a pregnancy loss, may be something that it needs to be discussed beforehand, whether removing it may improve the pregnancy outcome. So it's not too many surgical things that necessarily improve the risk in a pregnancy, but there are some very specific and unique situations that may need to be addressed first.
I also kind of comment on that as well, kind of segueing into that. As far as when we talk to women about healthy lifestyles, again, we very much support, like healthy body images and healthy at any weight. However, we do know that obesity itself can be linked to increased risks in pregnancy. So sometimes having a higher weight when you start the pregnancy, or a higher BMI is the other way to kind of look and think about that. So your kind of height to weight ratio. And it has been linked to things like miscarriages. It has been linked to infertility. It has been linked to gestational diabetes, preterm labor, and also congenital anomalies as well. And so some of the times preconception counseling is kind of talking through, if a woman has a higher BMI, about basically lifestyle changes that you can do to also minimize the risk to the pregnancy before you even get pregnant, and working with a team of people who knows you and can give you guided good interventions for that. Some women who have a substantially high BMI, we actually talk about postponing pregnancy potentially, and bariatric surgery being a potential in order to help to decrease those risks in pregnancy. So it's all individualized, but also another reason to kind of come see us preconception as well, just to kind of talk through what can be optimized prior to becoming pregnant, so that you can have the best, healthiest outcome for you and baby with your pregnancy.
Great, thank you. And I know that was one of our questions from the audience was regarding maternal weight, preconception and how to minimize risk. So thank you for answering that as well. So and just to ad lib to Dr. Garretto's comment as well, the only other surgical procedure that we sometimes discuss as well is if someone has had multiple losses of pregnancies previously, for example, in the second trimester. Sometimes we do discuss utilizing a procedure called a cerclage, which is a surgical procedure early in the pregnancy to prevent a preterm delivery or a loss. So sometimes that might be another term that other patients may have discussed or you may have heard in passing as well. Most of the time, though, that is not pre-pregnancy that we do that. The majority of that time, it's already when you are pregnant, but early in the next pregnancy. Perfect. So turning to the remainder of our panelists, specifically at Stony Brook, can you tell us any particular specialized clinics or offices or populations that we cater to here within the realm of maternal-fetal medicine? And we can start with Dr. Heiselman if you prefer.
Yeah, so one of the things that I think we do specialize well at is treating our women with a history of substance use disorder in a very multiple different specialties, multidisciplinary, non-judgmental, safe space. Back in 2016, we actually were the first kind of clinic hospital system to put forth a comprehensive multidisciplinary program called our MOMS program, Maternal Opioid Management Support, to basically make a comprehensive space that offered compassionate care for women who have a history of opioid use, whether that be active or whether that be something in someone's past. And we not only have us as maternal fetal medicine specialists, but we have behavioral health specialists, we have social work, our NICU team, our pediatric team, all of us work together in order to make the pregnancy as supportive as possible. And we also, with that, have multiple providers, both MFM, nurse practitioners in our group who actually prescribe buprenorphine, which is a maintenance medication that helps women with a history of opioid use disorder to be able to continue their sobriety journey, which sometimes they need within pregnancy and out. So not only are we able to take care of you for your pregnancy, but we can also prescribe the medications that make it a safe and healthy and happy pregnancy for you as well.
One of the questions that we had from the audience as well is not in the same vein, but similar, is that if someone is taking medications for different psychiatric conditions, one of them being substance use disorder or opioid use disorder, we are very comfortable as maternal fetal medicine specialists here, seeing those patients, following those patients, and really giving them comprehensive care for the best care for the mom and for the fetus in a compassionate way, like Dr. Heiselman mentioned. So.
Kim, I would add to that also that I believe one of the audience questions was also related to depression, anxiety. I think this segues nicely with our opioid program in the sense that many women with our substance use disorders tend to have other conditions going on. Depression, anxiety are common with it. So if the question from the audience was related to medications that you may need to keep your chronic depression, anxiety under control, many of those medications can be used in pregnancy. Many of them are with minimal risk to a fetus, and even with breastfeeding after. And that's one of the indications to come and chat with us and talk about the risk benefit. But the majority of medications actually are safe in pregnancy and recommended to continue, especially as pregnancy goes on and risks of depression, anxiety worsening increase, and especially into the postpartum period. So we have also a really nice relationship with our psychiatrists and a really great way to get especially our postpartum moms, or even during the pregnancy with a new diagnosis of depression, anxiety, to get them hooked in with psych and to make sure if medications are needed, desired by the patient, if they will help you with your plan of care or like how you feel overall for your chronic condition, that this way we get you hooked in early, treated early, and so you can enjoy both pregnancy and postpartum in a more productive and helpful, happy way. And so come and see us, discuss what your medications are, and we can talk about risk benefit of each one, or if changing to something safer in pregnancy is recommended instead.
Absolutely. It's a great point. And, just to reiterate too, that it is a lot of multidisciplinary and collaborative care that we do in maternal fetal medicine across all medical subspecialties. So I think that's very important to know that a lot of people are involved in looking out for both mom and baby on our team. So Dr. Choi, I did want to ask you about another specialized program that we have here at Stony Brook. Can you tell us about placenta accreta spectrum and how we treat that here at Stony Brook and what makes a patient fall into that category?
So we were named the Accreta Center of Excellence by the Safety Maternal Foundation in 2021. I want to start off by showing a picture of placenta accreta, if you can pop up picture number 4. So placenta accreta is a condition when your placenta abnormally adheres very deeply into the uterus. So at the time of delivery, you're unable to detach the placenta from the uterus. And this can have very significant severe consequences secondary to blood loss and operative complications. So I believe we're seeing more and more of these conditions. I think in the past 40 years, the diagnosis of placenta accreta syndrome has risen by greater than 4 times what it used to be. Probably secondary to the fact that we have a lot more C-sections these days, advanced maternal age, and uterine surgeries that increase your risk for it. Now, our MFM doctors are experts at diagnosing and treating a placenta accreta spectrum disorder. So we take a multidisciplinary approach. This involves a large number of people, including the MFM, obstetricians, anesthesiologists, the NICU team, the GYN oncology team, and sometimes even the urology team, general surgery, and interventional radiology team. We come together and we try to prepare in every way possible to make sure that you can deliver your baby safely. And this may include being able to get all our resources together to take care of massive transfusions, or even promptly alerting the doctors who need to be there for the delivery at any time of the day, evening, any hour. And that's sort of what we do in Stony Brook.
Great. Thank you. And I think that graphic is helpful too, because sometimes it is a little abstract to sort of envision what happens in a pregnancy, and once the baby is out, a lot of times we think that our job is done, but in placenta accreta spectrum, it can be quite risky. And so knowing that and recognizing that ahead of time and treating these patients in a multidisciplinary fashion has really helped to make our outcomes improved here. So I think that is a great highlight of our program here. The last program that I wanted to highlight, and I'll turn it over to Dr. Garretto, is can you tell us a little bit more about the fetal aspects of our care here at Stony Brook?
Yeah, so we have a very cool program going on. We call it the fetal program. It's with ourselves in maternal fetal medicine, with pediatric cardiology, pediatric surgery, NICU teams, and then any other pediatric specialties that are needed depending on the abnormality going on with our kiddos. So we may have a straightforward type of situation, club foot, we identify it on our ultrasound prenatally, and the family may have many questions regarding, okay, well, what happens with this after baby's born? What are the different modalities to treat it? Like, what should I expect over the first year? And so with this program, we have an awesome coordinator. Her name is Mary Beth, who will help to hook up the family with one of the pediatric specialties, in this type of case, like peds, orthopedics. So this way you have a little more information, although it won't be exact because they're going to want to look at the baby after birth, but at least to what you can mentally prepare for, so you know what's going to happen. Like, will the baby need the NICU? What will be the evaluation when the baby's in the hospital? What are you doing outpatient after? And in many cases, I think it just helps with feeling a sense of control over a situation that, we don't have complete control of. So that's one aspect of it. Things may be more complex, such as with a major congenital heart condition, an abnormality of the baby's heart that requires peds cardiology. And then we, can figure out the referral in terms of, does the baby need surgery immediately at birth? Is this going to be a delayed process where the baby ends up delivering here without an issue, but will need a surgery after? So what we end up doing is, you see us for an ultrasound where we may identify the issue, your doctor in your own regular office may identify there's something wrong and send you to us for the ultrasound to see what it is and talk about the different options at that point. But one of the important things is once we identify that, then we also can have a conversation, a consultation, talk about what to expect in the pregnancy. And then from there, we'll let Mary Beth know and get you, set up with all the services that you may need, especially if the baby needs the NICU. You can meet with them prenatally, have an idea of what the NICU experience is like, what to expect the baby will need at birth. So it ends up being a very, I think, helpful situation for the mom and family overall, just to have some more questions answered prenatally and a better plan of care to be prepared for a birth and a neonatal experience that may be a little longer than they might have expected with a routine low-risk pregnancy.
I also think, too, with our fetal program, in talking to some of my colleagues who unfortunately don't have the benefit and the resources that we do here, trying to get their patients to see some of the pediatric subspecialists can be a really hard road to navigate. And this program really just brings everyone together. So not only, like Dr. Garretto were saying, we're all on the same page, but it kind of streamlines the ability to see someone faster, just because we know you're part of our program. Everyone really takes ownership of that. And I think that that's one of the biggest benefits for our patients too, is not only getting answers, but also in a timely fashion. It is amazing how our coordinator and our kind of schedulers and everyone who works with us really moves mountains to try to make things happen as fast as possible for people. And again, within reason, but it is truly something that it's very patient forward and trying to make sure not only are we giving the best comprehensive care, but people feel supported and in a timely fashion as well, which is, I think, great for our patients.
Absolutely. And I think with the pandemic, that's only sort of heightened a lot of fears and unknowns with everything in general, but certainly with pregnancy. And I think having these established programs through Stony Brook really helps facilitate care, even if it's virtual. But now as things are getting more in person, even just logistically being able to have the patients come to our office, go next door for a fetal echocardiogram, seeing the NICU next to labor and delivery, this just all helps to alleviate a lot of patient fears and anxieties regarding different prognoses. So I think all of those have really helped facilitate care for our patients here. So I did want to just have a couple more questions from the audience that were coming in. And I can throw this over to Dr. Abu Zaid. One of the questions came in regards to sort of delivery timing. So with a single fetus in a healthy mom who has no other complications, when is the preferred delivery timing as far as gestational age for the baby to be delivered? And is there any research or current recommendations that's come out to support that?
Well, I see as long as there's no high risk issue with the mom or the baby, getting beyond term, which is 37 weeks, is our goal. And actually getting to your due date, which is around 40 weeks, is optimum. There have trials that have done specifically one trial that we usually refer to as the ARRIVE trial, where we actually even recommend potentially being induced a week prior to delivery, prior to your due date at 39 weeks. And that's been shown to be beneficial to the baby as well as the mom, and have had good outcomes. So as long as there's no maternal or fetal condition awaiting to 39 to 40 weeks gestation, and then preferably not going beyond 41 to 42 weeks beyond your due date.
Great, thank you. And I think again, just take home points from this whole webinar is also to have a conversation, to speak to your providers about your concerns, and to really explore what's the best options for you and your baby. But here within our practice and within our maternal fetal medicine area, we do have a lot of consultants that we work with, and also just again provide multidisciplinary care for patients to really come up with a great plan for them and for their baby. So next question from the audience is, do we work with any other hospitals in the area? So I don't know if Dr. Choi, if you wanted to take that one as far as any other collaborations that we have here in Suffolk County locally or beyond.
In general, we do work with our community hospitals. If there are patients that require delivery, especially if a preterm infant who needs NICU care or such, they would come to our hospital. We do go out to Southampton, that area, for our MFM care as well. And in the area, St. Charles is another hospital that we get patients from. We also get patients with continuity of care from even further elsewhere, like Northwell or Manhattan in the city, to come see us for their care. Some patients transfer, but in collaboration, I think the community hospitals in the Suffolk area are the ones that we do work with.
Great.
And to kind of, add on to that, we also are the regional perinatal center of Suffolk County. So we are actually the hub of where you have this kind of, I think, 5 hospital system that Dr. Choi is talking about, that kind of are community hospitals that refer into us due to the fact that we are, the higher level trauma, we have the higher level NICU, we have the kind of resources here at Stony Brook to be able to give patients good and safe quality care. So that is a kind of big highlight of our hospital, is that out of New York, of Suffolk County, we are the regional perinatal center and the preferred place to refer as well.
To add to that too, Dr. Heiselman, so we physically don't go to these other outside hospitals. We are physically located at Stony Brook as the hospital. What we're all referring to is we do take transport. So if someone presents at the hospital that doesn't have the appropriate level of care for either themselves or their baby, and then what we end up doing is we set up a transport essentially as the regional perinatal center with our EMS to get you and your baby over to the right location for whatever you or your baby's needs are. And so we work with a lot of outside practices like community OBGYN practices to see patients on the outpatient level, from any hospital system. It doesn't really matter. We are located throughout Suffolk County. So like Dr. Choi alluded to, we have an office in Hampton Bays. We have our Setauket office, which is right near the hospital in Stony Brook. We're in Bohemia, and we're in Comac as our major sites to see maternal fetal medicine. So we are scattered throughout. So there's almost always a place that will be convenient for a patient to come and see us.
And just to add to what Dr. Garretto just said, so not only do we accept transports from these other hospitals, but for if something comes up during pregnancy where your primary OB knows that the hospital that they normally deliver at can't handle the level of care that is required for either the mom or the baby, oftentimes we collaborate outpatient and prenatally. So before you deliver, to come see us, to have you understand what your plan of care is going to be, meet our physicians so that we can kind of transition that care over to Stony Brook even before you get to the hospital too.
Great. Great. Well, I think we do have a lot of questions that we covered, and just to highlight some of the topics that we covered, and also with collaboration amongst the different divisions and the different subspecialists is very important here at Stony Brook to be able to facilitate care at a larger level, but also at an individual level. And, just to wrap up our last sort of discussion is that we do have the physical locations, but of course, virtually we are available as well on this webinar for any other questions. And we do encourage you to follow us on Facebook on the University Associates in OBGYN handle on Facebook, as well as at SBM OBGYN to ask any other further questions or comments. And in addition, of course, if there's other consults that are inquired or other questions, you can always call our offices as well to make an appointment with one of us, which we will list at the bottom of the screen as well. But it's 631-444-4686, and we'd be happy to speak with you with more detail on specific points. And yes, I think we had a really fruitful discussion here. I don't know if there's any other closing comments, but I think everything a lot of the questions were answered, and hopefully we were able to put some of the audience at ease in regards to what we do in maternal fetal medicine. And even if you end up seeing us for high risk, we do really take great pride in our work here at Stony Brook Medicine, and we hope that you would continue to follow with us as well.